first guest is Mark Zulund, who is an associate professor at Duke, holding primary appointments in the Stanford School of Public Policy and the Duke Global Health Institute. He has secondary affiliations with the Nicholas School of the Environment and the Pratt School of Engineering. Ipsitha Das is a research scientist at the Stanford School of Public Policy, working at the intersection of environment, health, and development. Charles Nunn is a professor of evolutionary anthropology and global health, Gosnell Family Professor of Global Health, and the director of the Triangle Center for Evolutionary Medicine. Kuleni Abebe received her Bachelor of Science in Biology from George Mason University. She's currently a second-year master's student in the Duke Global Health Program. Rob Fetter is a Senior Policy Associate at the Nicholas Institute for Environmental Policy Solutions, working with the Duke University Energy Access Project. And Pamela Decca is the Associate Director for WRI India's Energy Program and leads the work on energy access, which strives to improve access to reliable, sustainable, and affordable sources of energy for social economic development. And our first panelist is Mark Zulund, and he's going to give a little background on what sustainable energy is all about and how it's linked to human health. So take it away, Mark.
Thanks, Mary. Just noting that Karen has her hand up in the attendee list, so I'm not sure if she'd like to ask a question.
Sure. Let's see. I don't see a message.
Okay. Hello?
Hi, Karen.
Yes. Just to let you know that I am here. That's it. Sorry.
Oh, thank you. Thank you for joining us. Thanks to everybody who's here. Thanks. We're going to jump back to Mark.
Great. So thank you, Mary, for that introduction. I'm Mark Zulund. I'm an associate professor in the Stanford School of Public Policy. I have a joint appointment with the Duke Global Health Institute. And I'm very happy to be here, also part of this panel, to talk to you about energy and its connection to health. I'm going to do a little bit of an introduction to the topic for those of you who maybe aren't as familiar with energy access challenges. And then I'll highlight a few of these connections in my opening remarks and talk about one ongoing project or initiative that actually both Ipsitha and I are involved in pretty heavily. So I'm going to share my screen. Hopefully this will work. Can folks see that? Yeah, great. Okay, so essentially, Sustainable Development Goal number 7 is all about energy. And it's phrased as ensuring access to affordable, reliable, sustainable, and modern energy for all. Now, each of these Sustainable Development Goals, of course, has a number of different objectives. But for SDG 7, the main objective is really the one that I've listed here on the right, which is ensuring universal access to affordable, reliable, and modern energy services. And this encompasses electricity and cooking primarily. So the two targets under this objective are universal electricity access and universal access to clean cooking fuels and technology. There are a number of other objectives under SDG 7 that highlight renewable energy and also things like international cooperation and energy efficiency. But really the crux of SDG 7 is about this universal access goal. And like all sustainable development goals, it's very ambitious, right? We've made a lot of progress on some goals, and on energy, there has been progress in some respects. But there's still a lot of progress that needs to be achieved for us to reach this goal. To start to dive into the connections to health specifically, I put up this figure in the middle, which is from a large systematic review that a number of colleagues and I did recently. Actually, Rob was involved in this too. So he should feel free to put his interpretation on it later if you'd like to. But what this figure shows essentially is connections between SDG 7 and other kinds of outcomes that we often care about development outcomes, outcomes that relate to well-being and so forth. And at the right, in the dark blue, you can see that large sort of about a third of the circle or the pie chart, slightly more, which is really about health connections. And these are health connections through direct measures of benefits to health, but also air quality, which is very intricately connected to human health. There's also a tiny little fraction that Rob will talk about later, which is about health facilities and healthcare. So that's, sort of highlighting an area where we don't have a lot of evidence. And what this figure is showing essentially is where we have a lot of studies and people working on these connections, and where we don't have so much. So, lots of studies related to energy and its role in health. And then on the outer ring, we show through the color coding scheme, the number of studies that show sort of positive connections between energy use and energy technologies and health or other outcomes. And those are the golden and sort of light yellow colors. Negative connections, which tend to be the gray, lighter gray shades, and then ones that are kind of ambiguous about what the link looks like. And those are the white colors. And you might ask, well, why are there so many negative connections between energy and health? And this is because a lot of energy use leads to pollution, right? And pollution harms health. On the other hand, some energy technologies actually improve health. So we can kind of see those in the golden connections. And just to sort of highlight the other point, there are lots of energy outcomes, energy-related outcomes that we might care about for development purposes. Just to lay a little bit of the framework for thinking about the scope of the energy challenge and energy access challenge. This is from the latest Sustainable Development Goal 7 tracking report put out by a number of institutions. And on the left-hand side, the figure that you see right now here is the share of population with access to electricity. Darker colors is lower access in this figure. And the bins are fairly crude here. So, that yellowish color, the middle color, is a large range of 50 to 99% roughly. And the darker brown is countries where access is between 10 and 50%. So very low access to electricity. And then on this new figure that I've put up, we can see access to clean cooking. And here the scale is a bit more differentiated and it's also different. But we have sort of 4 bins. Again, darker colors is lower access, and that darkest green color is 0 to 25% access to clean cooking fuel and technology. So there's a much larger gap that comes out on the right side. And in sort of aggregate terms, there are about 3 billion people who are cooking with solid fuels or sort of highly polluting fuels worldwide, and about 800 million without electricity. And the figure on electricity it masks the fact that a lot of people who have access to electricity also have poor access to electricity, so unreliable electricity. But the raw numbers are quite large. And there are also commonalities in geography. So, Africa, sub-Saharan Africa, parts of South Asia are less well served by energy resources and energy access. The other thing that you don't see in these static pictures is that there's been considerable progress on electricity access recently, but basically no progress on clean cooking globally. So the numbers are basically flat in terms of access to clean cooking technology, whereas the number without access to electricity is declining. Okay, so the last couple of things that I'll say, one is to highlight some linkages, and I think other panelists will speak about some of these connections. But the most obvious and the large sort of majority of studies that link energy to health talk about emissions of particulates and PM2.5 in particular, which is very fine particulate matter that enters the lungs and causes a lot of ill health. So that's kind of the leading sort of edge of energy and health. But there's a lot of work going on in that area. there are other emissions that also harm health, which are pretty well studied as well. So I've listed a few there: sulfur dioxide, carbon monoxide, ozone, but there are many other pollutants. And these are used by sort of technologies that use combustion processes, right? So there's energy that's being mobilized and that generates that pollution. Electricity is also essential for many modern services. So, Rob will talk about healthcare, I'm sure. You all probably know that we need it for Zoom and this webinar. And so, there are a lot of indirect connections through modern services that affect health. And that can, sort of extend also to mental health as well. And then I think Ipsitha in particular will talk a lot about links to health through women's empowerment and education. Empowered people globally use more clean energy than unempowered people. So that's a very important linkage, and they're important connections to equity. And then finally, lots of other indirect linkages, and maybe some of these will come out. I think Charlie and others will probably talk about links through ecosystem quality that also connect to how households are using firewood to heat their homes or cook. And you can think of sort of a number of other connections through ecosystem quality. The one project that I've been working on that I'd like to highlight, I do work in a lot of these areas, but a recent effort that I've been doing with Ipsitha, and it's sponsored by the World Health Organization, is to create a modeling tool. It's called BARHAP, the Benefits of Action to Reduce Household Air Pollution. And we are currently working on sort of this new snazzy version, which has a nice user interface and is easy to use. But essentially, the goal of this tool is to allow policymakers and practitioners all over the world to consider their specific country, think about cooking energy transitions and how to facilitate those transitions with policy interventions like subsidies, behavior change campaigns, bans on polluting fuels, et cetera. And then to use the tool to actually quantify the benefits and costs of those actions and advance the policy case for actually intervening in this fairly neglected sector where there hasn't been a lot of progress. So we're very excited about this tool and sort of the next version of it that's going to be much better than the first version that's publicly available right now. And we hope that it will be used widely by people in all kinds of settings to do important analyses linking energy access to health. And I'll stop there for my segment.
Thank you so much, Mark. That was a great introduction and overview. Ipsitha Das is our next panelist. Take it away.
Okay, I hope everyone can see my slide.
Yes.
Great. Hello, everyone. My name is Ipsitha Das, and I'm a research scientist at the Stanford School of Public Policy. As Mary said in her introduction, my research is at the intersection of energy, health, and development. And what I'll be talking about today is telling you briefly about my two lines of research, and then focusing a little bit more on the gender and sustainable energy piece of it. So my first line of work uses experimental and quasi-experimental methods to understand the drivers and impacts of cleaner energy solutions on rural households mostly, but also peri-urban and urban households in low and middle income countries. And as examples of cleaner energy solutions that I've studied or I'm studying or projects that I'm involved in are on improved cook stoves and solar mini grids. So what is common across all these studies listed here, most of which are ongoing, some are completed, is looking at the gender dimension of it, either looking at how women's empowerment drives adoption of clean or cleaner energy services or technologies, or how is it that women are affected from adoption or use of them. My second line of work is on cost-benefit analysis and contingent valuation of improved and clean cooking. And the BARHAP tool that Mark just described is an example of work in this domain. Other ongoing research is on looking at willingness to pay for cooking fuels in various peri-urban and urban locations in low and middle income countries. As far as field research goes, I have experience designing and implementing energy-related studies in South and Southeast Asia and East Africa. Here are some images from some of the field sites of projects I've been involved in. And as you can see in here, there is a variety of cook stoves in use in each study location. And the stoves that you see in here were primarily the intervention of interest in each project. So two key points I'd like to highlight here. First, while some cook stoves may be more efficient than others, local availability, the strength of supply chains, affordability, and a host of other factors determine what drives households to adopt these cook stoves. The second point is that stove stacking, which is the use of multiple stoves and fuels, is a reality. The image that you see on the top from Nepal is typical of households in urban areas where there is simultaneous use of firewood and LPG, suggesting that women have strong preferences about cooking technology. What I'd like to talk about next is a relatively understudied area in the empirical literature, and this is work that I've been doing with a lot of my Duke colleagues on looking at the existing literature on women's empowerment and energy access. So there is this bidirectional relationship between the two that is not studied extensively. Now, women on average spend over 3 times more time on unpaid care and domestic work compared to men. And this is in addition to all the adverse health impacts that there can be from use of traditional cooking methods. So there is potential in here for access to clean and affordable energy services to be able to increase women's empowerment. What's also equally important to study is the understanding of impacts of women's empowerment on energy access adoption and long-term use. And this is primarily because women are responsible for household cooking mostly, and they may have strong preferences about which cooking technology to use. Now, when we don't examine this two-way relationship, we run the risk of missing opportunities to advance both SDG 5 and SDG 7, but we also run the risk of exacerbating existing inequalities. In Mark's talk, we heard about the various energy-related outcomes that are possible. This slide here focuses on the pathways through which energy could affect women's empowerment in the long run. So what you see in here under direct outcomes, in addition to health and safety, there are time savings, increased productivity that could be a direct outcome of having access to a variety of energy services. But also of importance are indirect outcomes like community involvement, employment, leisure, and so on, all of which contribute to long-term goals of increase in women's empowerment. Now, based on the limited literature on this topic, my colleagues and I have listed sort of indicators that have been studied the most in this domain and the broad categories that they fall under. So what you see in here is we have more indicators in the economic and demographic domain, much less so in the social and political domains, and none in the psychological domain. Again, this is not an exhaustive list of indicators that can possibly be studied, because I just showed you on this previous slide of the various pathways in which energy services could affect long-term women's empowerment. So essentially, to be able to fully and comprehensively understand women's empowerment in the energy sector, there is a lot more that needs to be done as far as what are the various dimensions that we need to study, and whether there is a need for and whether there is a relevance to develop a type of a composite score or index of women's empowerment in the energy sector that could be of use to researchers and implementers alike. With that, I'll stop here and hand it over to Rob. Thank you.
Thanks, Ipsitha. I think it's actually our next panelist is Charlie Nunn.
Okay, hello everyone. My name is Charlie Nunn. I'm in the Department of Evolutionary Anthropology and also Duke Global Health. And I run TRISEM, that's the Triangle Center for Evolutionary Medicine. And it's great to be here to talk about some of the work that we're doing in Madagascar. I have a research program in Madagascar. Currently it's focused mostly on infectious disease, but I've worked on a variety of different topics in the past and the present, including household air pollution. And I think I'll try to start my slides up here. Just to give you a sense of the site. and what kind of things we're doing. Hopefully people are seeing this.
Yep, we can see it.
Okay, excellent. So I'm trained as an evolutionary biologist, and evolutionary biologists have a few sacred places in the world, places like the Galapagos Island or the Burgess Shale, where a lot of fossils come from, or Olduvai Gorge for human evolution fossils. And, Madagascar is one of those places, one of those sacred places. And one of the reasons for that is there's just incredible biodiversity in Madagascar, endemic species that are found nowhere else. And I've highlighted just a few of those species here, like the ii up in the left, the helmet vanga on the lower part, and one of my favorites, the geckos, the amazing leaf-tailed geckos up there on the upper right. And so I started going to Madagascar because of this biodiversity and to do work on infectious disease, especially in lemurs. And of course, as I went there, I got to know the people and their health challenges and became more and more interested in those questions and what could be done about that, what could be done about their health issues. And so I settled on a location, I guess I should have pointed this out on the previous slide, in the Northeast, in what's known as the Sava region, and in particular around Marojejy National Park, which is a beautiful and not very heavily used national park. And this is the village, one of the villages where we work. It's known as Mondana. And one of the things I'll point out to you is that if you look, hopefully you can see my cursor, what you can see is the border of the national park along there where the forest line is, because there's heavy deforestation right up to the border of that national park. And at least in this part of it, it's pretty well protected. And so one of the projects that we realized very early on, and I should mention this was through conversations with John Bartlett, and he even came out to the study site at one point, and we discussed different projects. And we realized that one of the projects that I could do would involve the connections between human health and conservation of biodiversity to really, pull in these two interests that I had. And one of the things to point out is that a lot of the reason for this deforestation is the harvesting of wood for cooking. This population uses wood almost exclusively. That's true throughout a lot of Madagascar. And in this particular population, they're not even turning it into charcoal. It's just straight, into under the cooking pot for making rice or whatever. And so we realized that this would be, an interesting system in which to understand this type of cooking, these cooking practices for human health, but also the effects of that on deforestation around this national park. And so we had a Bass Connections team that went out there in 2018 and did a fair bit of research. And I'll just show you, 3 or 4 pictures here that reflect the kind of situation there. First of all, this cooking is done typically, well, it can be inside, outside, or sort of a hybrid approach, but very often it is inside with no obvious ventilation, and cooking, as I said, with wood collected nearby. We used a variety of devices to measure carbon monoxide and also particulate matter. As you can see here, this is one of our Bass Connections team members on the right, and then a Malagasy master's student on the left holding a couple of these devices. We also collected data using spirometry. That was John Bartlett's suggestion. Very easy to use these handheld spirometers to assess respiratory health. And of course, we also did a lot of survey work and followed people collecting wood to measure how much wood that they used over time, as you can see on the lower right. And so just to give you a couple of really quick high level kind of results, not surprisingly, we find that particulate matter is really high in these settings. And it cycles through the day with 3 kind of peaks associated with mealtime. And we also found really high peaks associated with kerosene lamps, where we get this really sustained increase that lasts for sometimes quite a long time, associated with the end of the day and kids doing homework and things like that in their houses. Carbon monoxide, also extremely high, not surprising. very elevated near the cook stove, again, at all three of those meals, and in many cases, moving even outside of the cooking area into some of the living spaces. And then finally, the amount of wood harvested was really pretty substantial. We calculated it at about 3,200 kilograms per family per year. And we also were able to quantify the huge amount of effort that people have to go through to collect this wood, to split it, to season it, so that it will burn well, and quantified how that affects the burning. And then I guess just a final thing to point out is we did find some evidence for improved cook stoves in this particular population. This is a pretty somewhat more educated part of the national park. And they have a lot of tourism. The limited amount of tourism that's there does go through this village. So they have a lot of contact with NGOs and with tourists. But it's really rare. And people typically have multiple ways of cooking, as we just heard about with the stacking of different cook stoves. So that gives sort of an overview of the motivations for this work, really trying to understand the links between human health and conservation, biodiversity, ecosystem health. And with that, I'm going to stop sharing and turn things over to Kuleni Abebe, who's a master's student, just finished. And she analyzed some of the health data from Madagascar that we collected, especially during that Basque Connections project. So I'll turn things over to you, Kuleni.
Yeah, thank you, Charlie. Yeah, wonderful. Good afternoon, everyone. My name is Kuleni Abebe. As Charlie just said, I'm a second-year master's student who just recently defended my master's thesis, and I'll be graduating next month. But my thesis was actually an exploratory study titled Household Air Pollution from Cooking in Madagascar, Effects of Wood Smoke Exposure on Respiratory Health. So I'm going to share my screen so that you can see a bit more. Does everyone see that? It's looking good. Great. All right. So in order to really understand why household air pollution has a large burden within Madagascar, Charlie sort of touched upon these things, but I really want to discuss the three aspects of cooking practices in the country. So the first aspect is the type of cooking stoves used in Madagascar. Traditional stoves like a charcoal stove and a 3-stone stove. As you can see in this image here with my cursor, you'll have 3 stones, you'll have your cooking vessel, and then you usually put your fuel on right underneath, so you just have that direct heat to your cooking vessel. And these are very common in Madagascar, with over 90% of rural communities relying on them. The thing about traditional stoves, and I think Mark also mentioned this, was they inefficiently burn solid fuels, which can cause an increase of household air pollution and typically consumes more fuel. The second aspect I really want to talk about is the type of fuel, and it's commonly in Madagascar, with over 95% of households in Madagascar using either wood or charcoal. And as you see in this image here, this is actually from the site where they just left wood out to dry, sort of treat it before they use it as fuel type for cooking or whatever they need for the household. So the burning of these solid fuels, again, really increases the pollutant concentrations within the house. So lastly is the actual cooking location. And so cooking in locations with minimal ventilation does cause a buildup of these pollutants. So although cooking locations vary in Madagascar, as you can see in this image in the left here, in the left corner, this is somebody cooking indoors, and there's this large buildup of smoke, which you can actually see in the picture. And then on the right, you'll actually see that this is a cooking location outdoor, but there at least is more ventilation where the smoke can actually dissipate. So now that you have like a bit of an understanding of what cooking practices are like in Madagascar, our exploratory study really asked the question of what effect does HAP have on the respiratory system? And what was found was that when we did a multiple regression model that was conducted to assess the effect of HAP on lung function, the outcome variable was lung function measurements, which we obtained from spirometry. And our study indicated that a reduction in lung function was significantly associated with being the primary cook and cooking indoors. And this really does support other existing literature within other locations in sub-Saharan Africa. Before I really dive into what was observed with each primary cook and cooking location, it's really important to discuss what I would mean by lung function and what those measurements are. And so once the individual did a spirometer it gave us an output of the forced expiratory volume, otherwise known as FEV. And this measures how much air a person can exhale during a forced breath. So the unit of time for this measures is in seconds, which is indicated by the number in the subscript, as seen in FEV1 and FEV6. So this is just 1 second and 6 seconds respectively. So FEV6 actually really tries to estimate the amount of air that you just exhale, forcibly exhale as much as you can. So after all of that 6 seconds, it's really hard for you to breathe out more. So we're trying to get that good estimate of how much you're able to fully exhale. And so spirometry is actually the gold standard for accurate measurement of lung function and even diagnosing restrictive or obstructive respiratory conditions. And the graph below actually shows different readings for normal, obstructive, and restrictive lung function readings. So in reference to the green line here, which is that normal, what your normal lung function would look like when you look at the volume over time. Once you have sort of obstructive lung function, you actually have a reduced FEV1. So your ability to actually breathe out volume of air in 1 second is greatly reduced, as well as you can also have a reduced FEV6, so your total capacity to breathe out. As well as for restrictions, as you can see in this orange line here, you'll either have a reduced or normal FEV1 and a reduced FEV6. So giving you that crash course in lung function, what was then found in our main findings was that in primary cooks, the FEV1 was significantly decreased by 0.3 liters, as well as the FEV6 was also significantly decreased by 0.32 liters. In addition to that, cooking indoors was actually associated with a significant decrease in the FEV6 by 0.26 liters. So what does this findings really mean moving forward? It's important to note that there are some limitations to my study, which it is an exploratory study that actually does call for further need for future research. And some of that future research could really focus on investigating the personal and kitchen exposure to HAP in Mandana. In addition to that, chronic and acute respiratory symptoms should be looked at in relation to HAP. And lastly is to really investigate HAP exposure effect on children and adolescents, since there is a lot of task sharing done in the family. My study only included individuals over the age of 18. So we really did not observe the effect of HAP within this community or this age group. But moving forward, there's a lot of potential projects, and this could include the effect of improved cook stoves, as well as factors for uptake of these stoves. In addition to that is kitchen characteristics that could lead to improved ventilation in the cooking locations. So thank you everyone for listening to me. I'll stop sharing my screen and I'll let the next person talk.
Thank you, Kalini. That was really, really interesting. Next up is Rob Fetter.
Yes, and I'm just going to bring up my slides now. So that's working, right? So thanks very much. So we're going to switch gears here away from what the previous four panelists have been talking about to actually both, I think Pamela and I are both going to talk about a little bit more the intersection of energy access and healthcare. So, you know, rather than the drivers and impacts, I suppose, of getting modern energy access and how that reduces stress to human health. Now we're thinking about the importance of modern energy access for quality and effective healthcare. So this is the same. This is a version of the same slide that Mark showed early on, referencing again the systematic review that Mark and I and a host of a cast of thousands performed a couple of years ago. Where we, initially reviewed, we reviewed what was initially a set of 80,000 papers that had something to do with energy access and energy transition. And what we found as we, went through identifying relevant papers and identifying quantitative analyses and coding these things, these papers by the topics that they address, is that, as Mark alluded to, a very, very small number of them addressed health facilities in any way whatsoever. And so the main takeaway from this slide, and really from my entire segment here, is that there is just so much that we don't understand about energy access and high quality healthcare. And in some sense, this is like, I mean, in an ideal world, we would just know that the right answer is that we should provide energy access to all health facilities, rural, urban, and peri-urban immediately, and then things would get better. But in practice, of course, resources are limited, and so it's useful to sort of characterize the extent of limited energy access in health facilities, and then characterize what we know about complementarities between energy access and healthcare. And so this was one of the first attempts to characterize the extent of electricity access in healthcare facilities. Was a paper that was published in 2013 or 2014. I actually can't remember the exact year right now, but about 7 or 8 years ago. There was a systematic review of all of the data that was available at the time, which proved to be about a dozen countries and in sub-Saharan Africa. And that study found that about a quarter of facilities, this is ranging from level 1 health facilities and fairly and quite rural sort of health outposts, all the way up to regional and national level referral hospitals. About a quarter of those facilities across the board has no access whatsoever, not even a kerosene operated, sorry, not even a refrigerator to store vaccine. And that in about 3/4 of the facilities that did have access, there was some level of unreliability, where unreliable was defined as having an outage of at least 2 hours in the previous week. But oftentimes more. I'll say in my separate studies of electricity reliability, we often find that power outages can be numerous. They can be unpredictable. In one setting I've studied in northern India, there are between 5 and 12 power outages per day, typically lasting between 20 minutes and several hours, again, per day. And so, they're unreliable means a whole range of things, but some level of unreliability here. And that to the extent that we have longitudinal data over time, that the growth in access has been quite slow. But again, what I want to underscore here is this is this comprehensive study was 7 or 8 years ago, and there continues to be so much that we don't know. There have been some studies since then in a few countries, both from sort of the direction of healthcare surveys, so SARA surveys, service provision assessment surveys, this product called the DHIS2, which is a country level information database that some of you may be familiar with, and also in sort of the energy access side survey, so this thing called the Multi-Tier Framework Survey from the World Bank, has attempted to collect additional data about the extent of electricity access in health facilities, but that paper is still the most comprehensive one across more than just a handful of countries. Here's a small list of the things that we don't know and would like to know. What are the complementarities between energy access and other kinds of infrastructure, such as access to clean water or sanitation? If you provide a facility with off-grid access, because extending the grid is in a near-term time frame is unlikely, does that provide you with comparable quality improvements in services and so on? And what kinds of other constraints are present for facilities that may even have either grid or off-grid access, but struggle with the issue of affordability? There's a lot that we're trying to understand about business models and policies that are most effective. For instance, the sort of perennial challenge of getting public facilities to commit to paying bills. There's often a feeling that we're a public healthcare facility and we're providing a public entity, the Ministry of Energy or the electric utility, payment for services. Well, we're both on the government side. Why do we need to pay these bills? And so, that leads to utilities not wanting to provide grid service to healthcare facilities, and the problem snowballs quickly. there's also a lot that we don't understand about the effects of sort of complementarities between what we might think of as the healthcare production function. How is it that we produce high quality healthcare using electricity as one input, water as another input, provider effort as another input, and so on. And so, for example, this photo on the left is an image of a recent publication from Uganda that basically is built up from interviews with several dozen Ugandan healthcare workers who reported, just as the title says, our side of the story on what it's like to work in a facility with limited or unreliable access. Stories about delivering babies or trying to perform delicate operations like candlelight or by cell phone light, trying to control infection in the dark, often with no sterilization equipment like an autoclave, for example. The sort of demoralizing experience of watching the patient suffer or die when diagnostic equipment was unusable or something else went wrong. And sort of an overall impression about the extent to which this affects staff safety, the provider-patient relationship, the accessibility of records, the accessibility of telecommunications, and so on. So I'm going to stop sharing and just speak for a little bit longer about a project that I'm working on with the World Health Organization and a couple of other entities, including the World Bank, and also partners at other partners at Duke, some partners at UNC Chapel Hill, and some partners at the World Resources Institute. Is to produce this document that we're calling the Global Assessment of Electrification in Healthcare Facilities. And that will provide a thorough data stock taking of what we know about the extent of health facility electrification, as well as effective business models and energy efficiency trends and so on. One of the most difficult challenges of that report is getting getting energy access advocates and getting global health advocates to agree on the extent to which and the locations in which energy access is a core challenge. My sense here, just quite frankly, is that many providers of health services and experts in global health are used to working in low resource areas, and so they're used to finding solutions wherever you can. And it's not always clear that solving an energy challenge is the most urgent challenge that faces us. And so that's one of the, to my mind, that's another reason that we at Duke and elsewhere are trying to understand the complementarities better in order to know, how and where to make that case. So that's the end of my remarks. I'm going to turn it to Pamela, who's one of our partners on this global assessment that I just mentioned.
Thank you, Rob. Hi, and thanks Rob, thanks Mary and the whole Duke team for giving me this opportunity to share some of our thoughts on the work that we have been doing. So I'm part of WRI, World Resources Institute. It's a research organization. It was established way back in 1982 in Washington, DC. Now we have a global presence working in India, Indonesia, China, Mexico, multiple countries, more than 700 staff. So basically, we have been working on challenges which are at the intersection of environmental well-being and human and social development, social economic development. What I'll today focus on is the kind of work that we have been doing in some of the developing countries in sub-Saharan Africa and India, and particularly with respect to the current theme on health and energy access. So before I pull up my slides, I think this is just to kind of lay emphasis on how important this time is to discuss about energy access and health. So if you look at the numbers, we can put in perspective. So for example, during the COVID in India, I'm just pulling up the numbers on my end. So in India, we have reported around 172,000 deaths till now over the last, since 2000, over the last one and a half year. But if you look at the data from 2018 alone, in India, around 486,000, close to 500,000 children actually died during the first 28 days of life. So which is basically the neonatal mortality rate. Similarly, in 2017, 35,000 women alone died during childbirth, which is basically the maternal mortality rate. So while COVID has tried to push the agenda of health and energy access, I think overall this is a very pertinent problem which is faced by a lot of the developing world. And I think it's an opportunity for us to try to kind of move on this path of building back better by also focusing on the sustainable forms of energy, which will help in not just improving the health outcomes, but also in kind of dealing with this perennial challenge of climate change that we are faced with. So give me a second while I pull up my slides. Just a second. I hope you can see them now. Right. So I wouldn't go through this, but essentially what Mark and Rob have been focusing on, that electricity access is linked to all the outcomes across health, education, and livelihoods. And why I talk about education and livelihoods is because if you talk in the context of remote areas of India or other developing countries, while we require good health services, we equally require good education and livelihood services to be able to enable development in those pockets. And you can clearly see how during the COVID pandemic, we saw a huge number of people, actually millions of people coming back to rural areas. These are the people who actually had moved out of the rural areas just because they didn't have good facilities, including good health or education or livelihood opportunities. So in fact, the COVID proved to us that how there is an immediate need to actually focus on improving the health, education, and livelihood infrastructure across rural areas. So in the context of India, particularly, there is still quite a number of almost 30% of health centers across 10 states or 10 to 14 states actually do not yet have connection to electricity. Similarly, in education, we have a huge percentage, almost 36% of schools not connected to electricity. And across states, we see a lot of post-harvest losses. So this, as I said, this is the right opportunity to actually build on this infrastructure. And along with that, what we have seen is as you empower people with good sources of electricity, it also creates job opportunities. And that's something that we have been discussing over the last 3-4 years, that how, because the renewable energy and sustainable energy is decentralized in nature, they create these pockets of employment across rural India, or rural parts of the country, which actually can further help in empowerment and development in these locations. So what we have been doing in WRI is basically we have tried to take an integrated approach where we look at multiple aspects which need to come together. So one part is the data part, which Rob has kind of touched upon in the context of the work that we are doing with WHO and World Bank. The data part on what is available and not available, not just in terms of electricity, but also in terms of the health indicators, like at the facility level, what kind of institutional deliveries happen, how many people come in the daytime, how many people come in the night, how many people are asked to move to higher tiers of medical systems just because there is no electricity. That kind of data needs to be captured. On the technology side, obviously there's a lot of discussion around solar, but what else is actually suited to a particular region is something that needs to be checked. Finance has always been an issue, and particularly in the context of the public sector and the not-for-profit charity kind of organizations which run a lot of the health machinery across sub-Saharan Africa and India and such developing countries. Where does the money actually come from? So though the prices of renewable energy have gone down significantly, but still the upfront capital investment is quite humongous. So where does that money come from when you're talking about health centers which really do not have enough money to even pay the salaries of the doctors and the nurses? And all of these three factors actually kind of feed into the whole policy level discussions, the discussions around programs to integrate health and energy at different levels. And while we talk about the departmental kind of these different kind of areas, there's also the need to talk about it across departments. So more than often we see that when you go to the health department, there's this thing that this is a matter of the energy department to solve, and when you go to the energy department, the thought is that it's the health department's prerogative. So who actually kind of comes together to solve these problems? So we have been trying to work a lot with stakeholders across different departments, across different kind of levels, like at the state level, at the national level, and to an extent now at the kind of global level, trying to bring together the relevant stakeholders to take up some of these points for discussion. So particularly on the data, which we call the macro approach, I would like to show you this map. So how can data be useful? So this is basically data of one of the states in India where we are working. Basically, the color coding shows that the red is basically bad, which shows that these are some of the areas, the districts, as we call them, in the state of Assam, which still have 25% of health centers not yet fully electrified. So in fact, when you kind of plot this kind of data along with data on what are the climatic vulnerabilities. So for example, Assam is a state faced with floods. So you can plot that along with the health facilities and actually figure out which of the health facilities can actually access renewable energy more economically versus, extending the grid to those centers. So this is the kind of macro level approach that we are trying to work on across India and some of the countries in sub-Saharan Africa. And we're happy to share the link for these maps, which basically the whole idea is to develop this data, help people visualize, see this data and take decisions in either be it in making investments or in terms of identifying which are the key stakeholders to go to for, taking forward this, the energy access issue in these particular areas. Along with that, we are also working very closely with health partners. So, for example, it can be a government health partner, or it can be an international or a local NGO. When we say these are organizations basically which are providing the health facilities to the communities out there. So what we have been doing is we have realized very often that these organizations are run by doctors or kind of administrative people who really do not know where to go to in case they want to look at sustainable sources of energy. So we have been coming in as a knowledge partner to help them from the very beginning in terms of even ideating or brainstorming on how to integrate renewable energy into their work, to the extent of helping them figure out who the vendors could be, what kind of funding they could seek, help them writing proposals. And then finally, once the implementation is done, we help them do the entire monitoring and evaluation for the entire idea of, as Rob and Mark had mentioned, that what is the impact of renewable energy or sustainable energy on health outcomes. So it's kind of a long-term process of, a 3-year process where you work with them from baselining to monitoring and evaluating the kind of impact of these systems on the outcomes of health over a longer period of time. The one particular thing that I would like to emphasize on is the need to customize these solutions. So very often we have seen a lot of programs which talk about, a 10 kilowatt peak system being, installed across 50 health centers. What often happens is that unless a proper demand assessment is done in terms of the energy requirement or in terms of the type of organization, it's very difficult to sustain these solutions because many a times either there is no capital, no operating model, there is no financial kind of support to run these systems in the longer term, or sometimes the kind of load is not well planned enough to do justice to the 10 kilowatt peak system. Sometimes it is underpowered, or sometimes it is kind of too much of energy is extracted from that small system. So it's very important to customize the solution based on the loads available, based on the operating model, and based on the type of the organization. So that's what we have been trying, individually sitting with each and every organization to try to develop these kind of roadmaps, which consider the customization aspect to make the system sustainable in the long term. So I would like to share a few pictures of the work that we have been doing in some of these very remote locations. And these are generally areas which are somewhere sitting on the hilltop or somewhere in the middle of the forest or somewhere, cut off from the mainland due to floods. So this is some of the work that we have been doing with our health partners. And again, I would like to emphasize on the role of the health partners, something that Rob also had mentioned, that it's very important for the two worlds to come together. Unless you understand what the doctors need, what that particular hospital needs, it's very difficult to come up with a solution which is sustainable. And the whole idea of doing this work at the micro level is to gain the experiences and then feed it into the policy level and the programmatic level discussions which are happening at the state and the national level, so that the solutions and the programs which are being designed are more sustainable in the longer term. So essentially taking an integrated approach across departments and across different levels to make energy for health, to make it possible to realize the outcomes by looking at sustainable energy for health. I'll stop there and pass it on to Mary. Thank you so much.
Thank you, Pamela. That was wonderful. And I also want to thank you for being with us, because Pamela's in Bengaluru, India, and it's 10:30 p.m. at night there. So we appreciate you doing that. We've filled our hour. Usually we leave a lot of time for questions. If anybody has, we have a couple minutes. If anybody has questions and wants to put them in the queue, please feel free to do that. Otherwise, I'm just going to circle back. We had some other questions lined up. I guess something that I'm thinking about as I'm listening to all of this is, when you see these deficits of energy or challenges, how do you come in
sensitively to a culture like the cooking, like in Madagascar, and honor traditional cooking and bring in these new technologies and express concern for health without offending. It just seems like this, that we need a part 2 to this conversation to kind of understand that. Charlie, could you weigh in for a second on that, just since we have a minute?
Yeah, this is obviously, a sensitive issue, and we work with the local community to find out what things they're interested in and try to communicate, the motivations behind the work. I mean, it really highlights the importance of these kind of interdisciplinary approaches in global health, bringing in anthropologists and sociologists and others, to try to help navigate that, as well as the partnerships that are really crucial within the village, but also with some of the organizations that we work with on the ground in Madagascar. So I guess that's sort of a brief answer to that, but we do hold kind of community meetings and meeting with community elders and respected people in the community, and try to communicate what it is we're interested in, and try to hear what they're also interested in from the health side and the cooking practices side.
And maybe just also to jump in on that point, because I've been involved in a number of these studies with households in different populations in different countries as well. And, I think it is definitely true that people's preferences are widely varying. And, some folks put much more emphasis on traditional ways of cooking than others. But it really, in my view, from all of these discussions with people, the overwhelming constraint that prevents people from moving towards cleaner technologies is the cost. And most people, even if they sort of see some value in using traditional stoves for particular kinds of cooking, they also really want convenient, clean fuels for a lot of things, like, making tea, right? Or some kinds of food preparations that basically are identical with the traditional approaches compared to the new approaches. And it's really cost that prevents people from using those. And that cost is, a difficult issue, because these commercial clean fuels tend to be expensive for households. I think, linking the two, electricity and cooking together, is sort of the way of the future rather than LPG, because a lot of households are being electrified, but you still have the cost issue with electricity. And some countries provide electricity very cheap to households for basic purposes, but that's, tends to be expensive from a policy perspective also. So those governments are making trade-offs and choices. One project that we're working on right now in Kenya is, the COVID impacted the public budget. So the Kenyan Parliament decided, okay, well, we're going to put the value-added tax back on clean cooking products and solar panels and clean energy products, because we need the revenue. But then that has repercussions on all of these other social outcomes. So we're working on a cost-benefit analysis and informing the government about the implications of that revenue strategy. But I think there are a lot of these kind of unintended consequences stories that litter the different contexts in different places.
Thanks to you both. Does anybody else have any last words before we sign off? No. Well, I want to thank you so much, and thanks to all of our attendees. And it sounds like we need to definitely have a part 2 to this conversation. Thank you.
Thanks for organizing and for having us.
Thanks.
Thanks, everyone.
Thank you.
Thanks all.